So I'm going to be a little bit broader in my overview and kind of try and touch on a range of treatment options in the treatment of myelodysplastic syndromes. So before we launch into treatment options, I'd like to just begin by orienting you to normal bone marrow stem cell differentiation. So everybody's bone marrow has a limited population of stem cells, and these stem cells, depending on what genetic program is activated, will go on to mature and develop what we see in the peripheral blood as a mature white cell, red cell, or platelet. If they develop mutations along this genetic pathway that they are supposed to undergo to mature, they will get stuck and not emerge as a mature blood cell. And if we look in the bone marrow, we'll see a bunch of cells that are stuck in developmental arrest and no mature blood cells emerging in the bloodstream, reflected by low blood counts. So when we talk about myelodysplastic syndromes, just epidemiologically, these are very heterogeneous, and I'll try and illustrate some of the heterogeneity. These are clonal disorders, and they're clonal because they are driven by genetic mutations in progenitor cells in the bone marrow. Overall incidence as far as the myeloid neoplasms go is about 5 per 100,000, making them the commonest myeloid neoplasm. And this is a disease that increases with age. As you can see from the SEER database, the median age of patients is well over 60. So I think this slide really nicely illustrates some of the heterogeneity that is experienced by patients with myelodysplastic syndrome, and that makes it difficult for a physician to tease out how really this disease will progress, and also for a patient to understand what the prognosis of their disease is. So this is basically, if you were to imagine 100 patients within the United States developing MDS in the next 12 months, this is how their future could look. We'll start with the bottom. So the lightest purple represents 29 patients who will die of completely unrelated causes. We're really just looking at how these 100 patients are going to die at any point in their life. So 29 of them will die of geriatric-related causes. 24 of them, who are the purple patients, these are the patients that will progress to acute myeloid leukemia. And that happens when those immature cells that are stuck in developmental arrest really expand and they take over the bone marrow. And quantitatively, we say when they occupy more than 20% of the bone marrow. Out of these, the 2 people in yellow will be cured if they undergo intensive therapies such as bone marrow transplant. 7 patients here will die of complications related to low blood count, specifically low red cells, so anemia-related problems, heart attacks, strokes. The light blue up here represents patients that will die of problems related to infection. This may be linked to the low mature white cells these patients have that lower their defense against infection. 12 patients will die of problems related to bleeding. This is linked to the low platelets some of these patients have. 2 patients will die of complications related to iron overload that comes with excessive transfusion burden. And then up here are 6 patients that, while they're still in myelodysplastic syndrome, will undergo allogeneic stem cell transplant, which is a curative therapy in MDS, out of which 2 patients will be cured, 3 will relapse in green, and the patient in black will have transplant-related complications that they will succumb to. So again, this is over the course of their lives, how things will pan out for these 100 patients with MDS. So highly heterogeneous. And this is underlined by their molecular heterogeneity. So when we look with a range of genetic tools we have available to us with the wide availability of next generation sequencing, at the genomic composition of myelodysplastic syndrome. This is a German study that sequenced 945 patients, and they really looked at 47 genes of interest, and genes of interest are diseases that were already known to play a role in myeloid malignancies. And they found that the average patient had at least 3 mutations, and if you cluster these mutations, they really can be grouped into functional pathways that are dysregulated. And the top players among these pathways are pathways that regulate how genes are expressed, including DNA pathway methylation, changes in chromatin, which is when the DNA has to unwind for a gene to be exposed, to be read, turned into RNA and then protein. And the top layer actually is the spliceosomes, which I'm going to talk a little bit about at the end. Splicing determines once the DNA is made into RNA, before that RNA can be made into a functional protein, it has to be tweaked. Some segments have to be cut out, it has to be rejoined, and that's done by the spliceosome component. So, and lastly, if we link what we traditionally diagnose MDS as, meaning when you do a bone marrow biopsy, you look at the marrow with your pathologist. The pathologist will say, this is what I see. I see either a refractory anemia with ring sideroblasts, or I see a refractory anemia with excess blasts. And so these lower three here are representing patients that are starting to collect those immature, undifferentiated cells, which are the high-risk patients. And when we look molecularly at this clinical group of patients that we know are at high risk of moving into AML, they tend to have more mutational complexity. They tend to have higher numbers of mutation. So these are the patients on the right of this curve, which have more like 3, 4, 5 mutations, whereas the lower risk patients with the refractory anemia and the ring sideroblast, they tend to have 1 or 2 mutations. So complexity tends to reflect a more aggressive clinical course. But for the patient that walks into our clinic, what do we tell them about their prognosis in MDS? At this point in time, the most well-validated clinical tool remains the International Prognostic Scoring System, which was revised, and this is the revised version of it, but it still is really weighted based on the blood counts. How low is the hemoglobin, how low are the platelets, and how low are the neutrophils? The percentage of bone marrow blasts being those immature cells stuck in developmental arrest, and the chromosomal makeup. So the pathologist looks at the cells under the microscope and looks at gross changes in chromosomes, missing pieces, movement of pieces of chromosomes, and you get a score based on what chromosomal changes you have. So 2011 was the first time that an attempt was made to try and tie in the molecular, meaning genetic changes that we know about in MDS, to see if they add anything to the clinical markers we use for prognostication. And they were able to show that out of a panel of genes that they looked at, 5 genes were significantly able to influence prognosis on top of these clinical prognostic factors that are commonly used. And these include mutations in EZH2, P53, RUNX1, ASXL, and ETV6. And what this graph here shows is that basically if you were a low-risk patient without the mutation, if you had one of those mutations, you dropped to the dotted line here where you met the green curve, and the green curve is intermediate 1, so you dropped a notch on your prognostic score. Similarly, intermediate 1 with 1 mutation drops to intermediate 2, and intermediate 2 drops to meet the high risk. So you drop a notch in terms of a risk category if you have one of these adverse mutations. So it could potentially tie in with our prognostication in patients. Now I'm just going to segue into treatment, starting with low-risk MDS. So low-risk MDS, still the linchpin of treatment is supportive care. So it's driven by blood counts, symptoms related to low blood counts. And so I would say the mainstay of treatment there, because the majority of patients are plagued by low red cells and anemia, is stimulating better red cell production. And we do that with the use of erythropoiesis-stimulating agents. These include erythropoietin and Aranesp. The Nordic group in the late 90s came up with a very simple algorithm to predict which patients will respond to erythropoiesis-stimulating agents, because while most people will, some will not. And really, there's 2 things they look at. One is the transfusion need. So if you need more than 2 red cell transfusion a month, or your endogenous erythropoietin, which means this hormone erythropoietin, which is made by our kidneys, if it's really high, meaning if it's more than 500. These 2 markers, if these are present, they mean that you have a lot of ineffective red cell production already going on, and your body's really trying to stimulate it with high levels of erythropoietin. So giving more on top of that is probably not going to work. So if you have both of these parameters, the response rates are pretty low, like 7%. But if your transfusion need is less than 2 and your own erythropoietin levels are less than 500, response rates go up to 74%. So using these 2, we can pretty cleanly predict who's going to respond. In addition, there are smaller studies that show the addition of other growth factors like GCSF, which is a granulocyte colony stimulating factor, synergizes and kind of increases the effectiveness of erythropoietin. Then moving on to lenalidomide, which I would say is the next drug that has the most data treating low-risk MDS. In the early 2000s, Dr. List's group from Moffitt showed that in patients that have an isolated chromosomal abnormality in chromosome 5 called deletion 5q, and this has to be isolated, meaning without other cytogenetic abnormalities, lenalidomide is exquisitely effective in improving their red cell production. And 70% of these patients, there were 2 trials with slightly different dose schedules of lenalidomide, which is the myeloma drug you heard about from Dr. Jakubowiak, was very effective in this subset of patients, and 70% of them became transfusion independent for at least 8 weeks. as an extrapolation of this, Italian group in 2016 published data using this in patients without the 5q deletion. And they found that response rates were closer to 27%, which is not nearly as effective as in the 5q minus patients, but about a third of patients did become transfusion independent. And similar to what I showed you about responses of erythropoiesis-stimulating agents, the basal erythropoietin level in the patient also predicted response to lenalidomide in these patients. If you had high erythropoietin levels of your own, these drugs were less likely to be effective. So now we'll talk a little bit about hypomethylators. We know hypomethylators are FDA approved in high-risk MDS, so what about using them in low-risk MDS? And what about using them at slightly lower doses? So this first graph here is a retrospective study of 75 patients done in Italy, where they just looked at patients that were treated with various doses of 5-azacitidine and had low-risk MDS and said, did they have any responses? And they did. About 45% had responses, and that includes hematologic improvement, meaning the blood counts get better. And the ones who did have an improvement had a significantly better survival. So disease scores got better if you treated them and they had a response, and survival improved. So following that, a phase 2 study was undertaken saying, all right, let's use a lower dose of 5-azacitidine to avoid some of the myelosuppression and the low blood counts that this drug causes. So instead of 7 days, they did 5 days of 5-azacitidine, and they treated a group of patients, and they found that, in fact, they did have around 50% of patients that were responders. And in this study, they also looked at a predictor of response, which is a gene called PIPL, which is phosphoinositol phospholipase. It's earlier been identified to respond to reflect very cleanly if the 5-azacitidine is working, because the RNA levels of this gene come up, and that usually happens a little bit before the response. So it's like an early predictor of treatment response, and it kind of bore out in this study, which was interesting. And then MD Anderson did a randomized study where they randomized patients to either low-dose 5-azacitidine or low-dose decitabine. So it was 3 days of decitabine or 5 days of azacitidine, and they treated low or intermediate 1 risk MDS. And they found that actually decitabine had significantly superior responses, and the CMML patients specifically benefited from decitabine. And lastly, just to introduce you to the idea of oral hypomethylator. So there is an oral formulation of 5-azacitidine that early phase studies have shown has about a 30% improvement in hematologic parameters, so blood counts improving, transfusion independence, and is now being looked at in phase 3 testing. And this is a study that we are also doing for low-risk MDS at the University of Illinois. Lastly, I'll touch a little bit on a more unique method to try and improve red cell production, and this is a class of drugs that target TGF-beta signaling. So TGF-beta family of ligands, what they do is, these are proteins, when they bind to their receptor on the erythroid, like progenitor cells in the bone marrow, they basically block late-stage development of those red cells, so they don't make it to actually producing mature red cells. So what these drugs do is they function as ligand traps. So they kind of mimic the receptor, their receptor fusion proteins, and they soak up all that ligand so it cannot bind to its receptor. And that in turn prevents this SMAD pathway from switching on. And this SMAD pathway, when it's blocked, late-stage erythroid development proceeds and red cells are produced, and that is reflected in the increase in hemoglobin of 2 to 3 grams that is seen in these patients and is sustained over a year. And this is just a waterfall plot kind of showing some of that improvement this is the red cell transfusion dependency of patients who had, in the pink, they had a low transfusion burden, meaning less than 4 units in 2 months, and this needed more than that. So it's pretty impressive that even patients with very high transfusion burdens, almost 1 a week, responded. And so the phase 3 study for this has fully enrolled, and the phase 2 studies for both these drugs have been published last year. And finally, we'll talk a little bit about low platelets. About 10% of patients have really low platelets, and there is a movement to try and stimulate platelet production using drugs that are already approved for other disorders with low platelets like ITP. These stimulate the thrombopoietin receptor and stimulate platelet production just like normal thrombopoietin, which is the hormone that regulates platelet production, binds to this receptor. The drug binds similarly and stimulates the same pathways, and you can see sustained improvements in the phase 2 study in platelet counts compared to patients that got placebo. The caveat to this is that this receptor is also expressed in stem cells, and so there was some theoretical risk, and some studies in high-risk MDS bore this out, that it can stimulate those immature blast cells to divide also. So really the safety was important, and in these low-risk patients with less than 5% blasts, they did not see any increase in AML. So now we'll just talk about high-risk MDS. So high-risk MDS currently has 2 FDA-approved options, Vidasa and Dacogen, which are 5-azacitidine and decitabine, that were FDA-approved in 2004 and 2006, respectively. What we know about these agents is the median duration of response is 10 to 14 months, which means that after this, the disease generally progresses or comes back. And at that point in time, a study from 2011 looking at 4 pooled studies of patients who got Vidasa and progressed after that, we don't have a lot of great options. And standard, whether you use high-dose chemotherapy, low-dose chemotherapy, supportive care, all the survival curves are less than optimal. The only plateau really comes with patients who go to stem cell transplant, where you do have survival, long-term survival. So this is clearly an area of unmet need. So a few studies tried to see that, number one, can we improve response rates to the hypomethylating agents, which currently stand at somewhere between 40 and 50%. And so they did this by adding drugs like lenalidomide, which we talked about earlier, and vorinostat, which is a histone deacetylase inhibitor, which also kind of targets this whole epigenetic silencing that really drives MDS. And unfortunately, none of these drugs panned out in the phase 3 study to improve survival. However, when they looked at the subset of patients with CMML, they found that the combination of azacitidine and lenalidomide did significantly improve response rates. So that's something to think about. How can we make the current hypomethylating agents better? So one of the limitations of hypomethylating agents is that they only really act, so when the cell is dividing, the cell goes through one part of the cell cycle called the S phase, where it's synthesizing DNA, and that's really where these drugs are effective. And they have a short half-life, and they're only active in the S phase, and therefore the idea is that if we can prolong a cell's exposure to these drugs, they may become more effective and demethylate genes more effectively, and when you demethylate a gene, it's actually expressed. The silencing is removed. So ASTX is an oral decitabine, which is combined with an enzyme inhibitor of cytidine deaminase. Cytidine deaminase is an enzyme in the gut and the liver that quickly inactivates decitabine. So by inhibiting that enzyme, the drug life in the serum is markedly increased and prolonged. So this drug is entering phase 3 testing and has had pretty nice results and sustained levels comparable to the IV formulation. So it will be nice to have an oral option. Guadocytabine is decitabine linked to another molecule called deoxyguanosine with a bond. And so the idea is that it's going to take time to break down that bond and slowly release the decitabine. So again, the cells will have more prolonged exposure to the drug. So really prolonging exposure. Some of the other mechanisms that are targeting epigenetic silencing include, again, histone deacetylase inhibitors, BET proteins. These are also proteins that kind of read the DNA. Lysine, LSD inhibitors. These are lysine demethylase inhibitors. Again, these are all things that change the way the DNA is read. Some of, in addition to targeting epigenetic mechanisms, which is where a lot of the focus is, there are other targets under investigation in MDS, and that includes some of the immune checkpoint inhibitors, which you heard a little bit about in myeloma. And again, similar to myeloma, targeting mechanisms of immune evasion in MDS has not panned out to be very successful, at least in single agent. They are still being explored in combination, combining several checkpoint inhibitors, combining checkpoint inhibitors with hypomethylators. So there are still investigations to optimize these drugs, but as single agents, they haven't been very exciting. Other areas that are being targeted include IDH mutations, which we'll talk a little bit about, and activated signaling pathways like the PI3 kinase and the polo-like kinase pathway. So we'll touch a little bit on IDH inhibitors. So IDH inhibitors, specifically the IDH2 inhibitor, was FDA approved for the treatment of AML. About 10% of AML and 10% of MDS patients have this mutation. The end result of this mutation is also a mechanism of epigenetic silencing. And so the IDH inhibitors, kind of like the hypomethylators, take a while to work because they lift the silencing of genes, DNA have to be expressed, cells have to mature. And so this is kind of these are 15 patients that were treated with the IDH inhibitor with high-risk MDS, and the red and the blue represent the responders. The red ones are the hematologic improvement, and you can see the x-axis is in months. So there were some really prolonged responses in patients that had had multiple prior therapies, which is pretty encouraging because, as I showed you, people after progressing on hypomethylated historically don't do well. One of the important things to bear in mind, which has also emerged from the AML data with IDH inhibitors, is that there are some mutational subsets that do not respond to these drugs, and that includes patients that have mutations in RAS and P53. So another reason that molecular profiling may help you pick what drug not to use. Rigosertib is a pathway inhibitor of polo-like kinase and PI3 kinase, which are just activated signaling proteins that stimulate a cell to divide. They, while in unselected group of higher risk MDS patients, they did not show superiority over best supportive care, but when they teased out the really high risk MDS patients, they did have a survival benefit, and so now they're being looked at in a phase 3 clinical trial in the very high risk MDS patients after progression on a hypomethylator, and this is also a study that we're currently doing at UIC. NED elation is kind of interesting because this is a really novel way to target a disease, and it's really shown some relevance in myeloid malignancy. So it's kind of interesting. It's not necessarily active in other malignancies. And this is really looking at the ubiquitin proteasome system, which is the cell's way of managing protein waste. So when a cell wants to get rid of a protein, it basically uses this ubiquitin ligase system to put a red tag on it. That's a ubiquitin chain. And when that's on a protein, it gets targeted to the proteasome for degradation. And so what happens is that for this ubiquitin ligase system to work, it has to be co-activated by the binding of this NED protein. And NEDylation inhibitors basically bind to NED and create these NEDylation NED adducts and prevent NED from activating this cascade. So what happens is all these dysfunctional proteins start collecting and they're not broken down because they're not being targeted for destruction. And you can kind of see in the phase 1 study, this is the same patient pre-treatment and after treatment, those NED, the drug NED adducts are collecting in the bone marrow, and proteins that should be degraded, which in this case is CDT1, start to accumulate, and those are the blue dots that weren't there pre-treatment, but you can see these dysfunctional proteins are starting to build up, and eventually when enough of them build up, the cell has to die. And so this drug has shown very promising results in combination with azacitidine in AML and is now being studied in a randomized phase 3 study, azacitidine versus pavonistat plus azacitidine, and that includes high-risk MDS. So this is going to be interesting. This is just an algorithm, which I'm not going to go through in the interest of time. But essentially, when you see a patient with MDS, first thing you want to know is, I would say you want to know a little bit about the genomic composition of the disease, and then you want to know if they're low risk or high risk. And we talked about low risk and the management of anemias and cytopenias. And then with high risk, you want to start thinking about transplant early. Think about hypomethylator use, and if after failure of hypomethylating agent, really think about clinical trials, because there are several new drugs that are coming that are pretty interesting and are in advanced phase testing. And for my last slide, I kind of wanted to give an illustration of kind of what Dr. Stiff talked about, the really exciting pace at which science is moving. And an area that's been really exciting in MDS is spliceosomes. So I talked to you a little bit about spliceosome mutations at the beginning. Spliceosomes, again, are the machinery that process mRNA before it becomes a protein. And 60% of patients with MDS have spliceosome mutations. So this is the original sequencing study from 2011, and this is one of the spliceosome mutations, and these are the different types of MDS. And you can see almost all patients have some sort of spliceosome mutation. And so in 2016, there was a very elegant study out of Memorial Sloan Kettering trying to really understand why the spliceosome is mutated. It's clearly a relevant target. And when you remove it entirely from a mouse, the mouse dies of bone marrow failure. So when one gene is mutated, the mouse, the cell is really dependent on the normal allele. So what do the spliceosomes do, and how can we use this to target these cells? So what happens is when you have 2 copies of a spliceosome gene, such as SF3B1, the SF3B protein is made, and it forms a complex, which is called the SF3B complex, and there's lots of this complex, and then it integrates into the spliceosome and binds to mRNA and processes it. When you lose one of these genes by mutation, the amount of SF3B complex goes down a lot. There's very little of this protein left, and the spliceosome complex is markedly reduced. And so if you then further inhibit the spliceosome in a cell that's already very deficient in it, you force it to die. Because it's very dependent on the little spliceosome it has left. So if you could just get rid of the last bit of spliceosome machinery, the cell will be forced to die. And so this was, the mutation was first identified in 2011, and earlier this month there was a Nature paper showing from a biotech company in Cambridge, they've developed a spliceosome inhibitor that they use to treat CMML. CMML is a disease characterized by spliceosome mutation. And they showed really nice reduction in disease burden in patients with the spliceosome mutation. This is the human CMML infiltrating the bone marrow in the untreated mouse. This is after treatment with the spliceosome inhibitor. And the really nice control they showed was they used CMML from a patient without that mutation to really show selectivity, and you can see the drug did nothing. So it's really selective for patients who have very low spliceosome, and you just knock that last bit down and the cells die. So this is kind of precision medicine taken from the plethora of genomic information we're getting, really distilled down to make a drug. So I think this is what kind of makes being in this field exciting at this time. So that's it. Thank you.